Good afternoon. Welcome to the SMBP Forum. You are in the right spot if you are here for the Self-Measured Blood Pressure Monitoring Forum, making SMBP more efficient and sustainable. We're going to just give it about 1 minute to allow participants to come in from our Zoom waiting room. We'll get started promptly at the top of the hour. And thank you so much for joining us. Just give it a few more seconds. All right, it is 1 o'clock here on the Eastern time, so we're going to go ahead and get started. Hello, everyone. My name is Leanne White from NAC, and we are excited to present our Million Heart Self-Measured Blood Pressure Monitoring Forum this June 13th, making SMBP more efficient and sustainable. Just a disclaimer that the Million Hearts SMBP Forum was developed with support from the Centers for Disease Control and Prevention. Just kind of going over some housekeeping items real quick. I just want to let you know that you have 2 options to dial in today. You can dial in via phone call with the phone numbers listed in your invite, or you can also join using computer audio. You will have the ability to come off mute or request to become off mute, but I just want to let you know that video and audio for this event has been disabled by the host. We will have opportunities for participants to engage. If you would like to come off mute, simply raise your hand and one of the panelists will go ahead and unmute you. We also have a couple options to communicate during our forum. We have a question and answer option. We would like to reserve this only for questions, so please submit your questions throughout the forum in the Q&A at the bottom of your screen. We also have chat open, so we would love to hear your thoughts, get feedback, share comments, and connect with one another via chat. I'm now going to hand it over to Judy Hannon from the CDC to give our welcoming remarks. So Judy.
Thank you so much, Leanne. I'm very excited about today's SMBP Forum and appreciate everyone's attendance. If you've registered for these forums, you may have noticed that there isn't another one coming up. We will be taking a break over the summer, and we're reassessing the value and the need for these forums. We will be asking for your feedback at the end of this session, so please get your thoughts together regarding what would you miss most if these stopped, and whether or not you see a need to continue these forums. In addition to the survey at the end, feel free to put your thoughts and opinions in the chat as we go on, as you're thinking about them on today's call. But try to save the Q&A for questions for the speakers for today's content. So the chat, feel free to talk about the future of the forum, chat with each other, and Q&A is for dialogue related to the topic. So I do want to take a few moments just to sort of share we've come a long way in our journey, collective journey across the nation to expand access to and uptake of SMBP nationwide. In Million Hearts, for us, the journey somewhat began in 2012 when we saw the Agency for Healthcare Research and Quality that had conducted a review that demonstrated with strong evidence that SMBP with clinical support was more effective than usual care in lowering blood pressure. Following the release of that report, Million Hearts developed the SMBP action steps for public health practitioners in 2013. And then we were real excited to see in 2015 the USPSTF updating their blood pressure screening recommendation to include SMBP as an alternative to a very hard to use ambulatory blood pressure out of office blood pressure measurement for the diagnosis. Payers began to use that recommendation as a rationale to cover upper arm blood pressure devices. And then, of course, in 2017, AHA-ACC National Clinical Guidelines were updated to recommend the use of SMBP to confirm the diagnosis of hypertension, titration of blood pressure lowering meds, and for follow-up and monitoring after initiation of drug therapy. For more details on those guidelines, I really suggest you review the Kate Curley presentation from our March 2023 SMBP Forum meeting. It's important and it's helpful when you're trying to convince others about the need to do this, that it is guideline recommendation. We began these forums in June of 2018 as an opportunity for clinical, public health, and community-based partners to exchange best practices and promising practices, to identify solutions to common obstacles, and to share resources to accelerate SMBP uptake. You, the attendees, have been as much a part of the faculty as any of the experts we have brought on. Besides your advice for what has worked for you, you have also helped us determine priority issues that need to be tackled nationally. We've since convened 25 SMBP forum meetings and have extended our listserv of SMBP implementers and supporters to about 1,200 folks. And we continue to see high attendance at these forums. A couple of other notable updates near the end, and I just realized I'm only hitting the top. In 2019, AMA issued the new SMBP CPT codes and billing, and which became billable for Medicare patients in January 2020. We had the validated device list come line. And throughout all this time, CDC, Million Hearts, NAC, AMA, AHA, and HRSA have produced hundreds of tools, resources, and trainings to drive national use of SMBP through multiple programs and initiatives. Additional partners like the Y and the Preeclampsia Foundation have helped make strides in driving SMBP use as a lifestyle program and an invaluable clinical tool to diagnose and manage hypertension. In April of this year, Million Hearts convened SMBP implementers in the pregnant and postpartum persons to advance SMBP as an accepted standard of care that is accessible to all pregnant and postpartum persons. More to come on the results of that gathering. And while many of you have been busy implementing SMBP and can share with us that it's probably been a bumpy road, and we still have much further to go, but I can say clearly SMBP remains an important tool in achieving the Million Hearts goal of 20% improvement in blood pressure control by the end of 2026. And all of this is to say thank you to you for being part of the journey with us. We look forward to advancing our partnership to make SMBP with clinical support a reality for all people with elevated blood pressure who may benefit, and look forward to your feedback about the need to continue these forums. With that, we can go over to the agenda. I promise we'll get on to some really important stuff today. As you can see, our featured topic is making SMBP more efficient and sustainable. Many of you implemented SMBP in early stages as things have changed, and the concept of how can you build this most into the workflow, make it as less onerous as possible with the best outcome. So first, we'll have Meg Metter from NAC remind us about the difference between SMBP and remote physiologic monitoring. And then we have Matt McReynolds from AMA, who'll provide an update on state Medicaid coverage and maybe a couple other things from AMA. If you haven't heard yet, 4 more states have established Medicaid coverage this past year. Then Deb McGrath will speak to workflows that healthcare organizations can pursue to efficiently implement SMBP. We then have our usual lots of time for questions and answers, so 20 minutes or so to explore solutions to improve efficiency and sustainability of SMBP with our presenters and the forum members. Have your thoughts and questions ready, please. We'll then close out with key updates, our survey, and closing remarks. I'll now pass the meeting over to Meg, our longtime partner on this road, to help clarify once again what SMBP is and what it is not, to ensure our work aligns with the best evidence to provide optimal care to the 1 in 2 adults in this country with hypertension. Meg?
Thank you, Judy. All right, so I'm just going to refresh here on the difference between these two terms. I think it's there's a lot of vocabulary that's out there around self-measured blood pressure. So starting on the left in the pink box there, self-measured blood pressure is measurement that takes place outside of the clinical setting of blood pressure. It's actually a type of remote physiologic monitoring. It's used to confirm a diagnosis of hypertension or treat or manage hypertension for those who are already diagnosed. And it's a tool that can really help patients engage in their own care. Ideally, patients take their blood pressure twice in the morning and twice in the evening for 7 days. And they do that to generate an average blood pressure for clinical action. SMBP reimbursement requires documentation of at least 12 blood pressure readings or measurements per month. And then I'm going to switch over to remote physiologic monitoring. And this is the use of devices for remote monitoring of physiologic parameters. So that could include blood pressure, but it also includes weight or pulse oximetry, respiratory flow, and other indicators for medically complex patients. The medical devices used must be defined by the FDA, and the service must be ordered by a physician or qualified health professional. And for reimbursement purposes, it requires 16 days of blood pressure measurements per month. So not 12 readings, but 16 days per month. So I think the uses, the population of focus, and the reimbursement codes and requirements are actually very different for each. So it's best to be specific about what you mean. And really quickly, I think we often say RPM and say remote patient monitoring. And this is a pretty loose umbrella term, and you can see why it's difficult to understand what somebody means when they say that. So we encourage you to, if you mean SMBP, to say that. And if you mean remote physiologic monitoring, say that. Thanks.
All right, thanks, Meg. So I'm really pleased to introduce, we have some wonderful speakers today. Matt McReynolds is an ecosystem analyst with improving health outcomes at the American Medical Association. Matt conducts market research and provides policy and program support addressing interventions for cardiovascular disease prevention. He tracks trends in remote monitoring, self-measured blood pressure, and medical devices, and he assists with the U.S. blood pressure validated device listing, which is an independent listing of blood pressure device validation for clinical accuracy. And we have Deb McGrath, who's joining us. She is a nurse practitioner and healthcare IT professional with extensive experience in successful HIT implementation and optimization, particularly for federally qualified health centers. She leads SMBP initiatives, including Million Hearts Health Centers and patient engagement programs with pharmacists and insurers. She has helped many practices create a foundation for the ongoing development of HIT systems that support the work of the practice for many years and is able to add a unique perspective for both the clinical and information technology points of view. So welcome to our speakers. We're excited to hear from them, and I'll now turn it over to Matt.
Great, thanks so much, Leanne. Hi, everyone. Very excited to be talking with you today. I'm Matt McReynolds, Ecosystem Analyst with the American Medical Association. And I work in the division of improving health outcomes, where our mission is to address chronic disease prevention with a specific emphasis on cardiovascular disease and blood pressure control. So today, I want to speak briefly today about the state of coverage for SMBP devices and critical services among public payers in the U.S. Go to the next slide whenever you're ready. So as part of our mission to prevent cardiovascular disease, at the AMA, we've committed to a goal of bringing 5 million patients to BP control, with 1 million of those being historically minoritized populations. And so as part of that effort, we have really centered coverage for Medicaid as a core area of strategic focus in our efforts. And we started out to look at this population. The first step was really examining coverage. So we conducted a national survey of state Medicaid programs, assessing coverage for both those SMBP devices and cuts themselves, as well as the clinical services. So the survey you see here addresses fee-for-service programs in each state. And we survey published resources like fee schedules, provider manuals, and Medicaid bulletins relevant to coverage. In doing so, we've maintained a landscape of SMBP coverage status for the past several years and have been working with external organizations to advocate for expanded coverage. We've seen some great expansion over the past couple of years, and like Judy mentioned at the start of the presentation, from our landscape last year, we have 4 new states that have added coverage for SMBP devices. Those are Kansas, Georgia, Pennsylvania, and South Dakota. And we're working really hard this year to get some more states on board as well. So we expect to see several more states add coverage for devices by the end of 2024. Great. And so, like I mentioned, we continue to update this resource annually, and have attached a link to the QR code here on the right. We encourage you all to take a look at the resource, see where coverage stands today, where there are gaps, and if you have opportunity to contact your policymakers work with your state organizations to start conversations about expanding coverage for this important population. All right, next slide. Great. And so in addition to assessing the national coverage landscape and advocating for expanded coverage, the AMA is very interested in increasing utilization of SMBP benefits in states where there's existing coverage and also where we've seen new expanded coverage. So starting at the tail end of last year and in 2024, we launched a coverage utilization initiative to partner with state medical societies and physician champions to increase awareness and education about how to start administering these benefits. Currently, we are working with Michigan on an initiative to increase utilization for Medicaid serving physicians, but also plan to advance this to several other states this year. And I want to mention on this webinar as well, if you or your state is interested in this effort, your healthcare organization, I put my contact information on the next slide and would really welcome any conversation about starting the process, helping out your organization to get the SMBP implemented for this population. If you're interested in learning a little bit more, I did put the QR code there on the last slide for Michigan, kind of show you some of the resources that we're working with and what we could do for your state. And happy to have conversations about that in the future. So I appreciate you taking the time. Please feel free to contact me. Here's my contact information, and look forward to hearing from you. I'll pass it back to Leanne.
Wonderful. Thank you, Matt. I appreciate you being here today. We look forward to the questions that come rolling in. All right, so I'm now going to hand it over to Deb McGrath, who will take us through streamlining and sustaining SMBP. Deb?
Thanks, Leanne, and thank you for having me today. I'm looking forward to the conversation. So as you think about your SMBP monitoring services that are being offered, is it been incorporated into your practice? Is it being widely used as much as you would like to see it used? I hope what we can offer today is some framework for thinking about the SMBP monitoring services that are being offered and the elements that could be evaluated, revised, improved, so that SMBP is more streamlined, is more cost-effective for your practice. Next slide, please. So the first thing is thinking about costs, right? We're thinking about costs, we're thinking about streamlining the processes, and then thinking about potential revenue streams. So as you think about costs, some things to think about might be, does the patient have a DME or pharmacy benefit for a device and the cuff itself? Can you have a conversation with insurers in your payer mix to think more about how those devices could be on site with you, that you're actually ordering them and getting them billed through the practice itself. We're starting to see those conversations come about, and we're a little bit encouraged by the success that we're seeing here in Pennsylvania. Also thinking about a third-party partner to curate all of the blood pressure values and put them in one place for you. And on page 10 and 11 of the SMBP toolkit, which is listed in the resources for this talk today, there's a really good sort of decision tree for how you engage with a third-party partner. And then thinking about how you can employ technology like text messaging or messaging through the patient portal and automating those messages where possible, just to reduce the cost of the program itself. Next slide. Streamlining the processes mean using the right person for the job so that you are freeing up more expensive staff to be able to do just the things they need to be able to do. And on page 7 to 9 and 13 of the SMBP toolkit, you can be walked through the ways that the team can be used. So thinking about that enrollment and initial monitoring phase as non-licensed staff, and then the treatment, stabilization, and graduation using licensed staff. And I want to put a plug in for clinical pharmacists and incorporating them into the team. Next slide, please. So in terms of streamlining the processes further, how do you make the default the right thing to do? How can your EHR be configured to automate things like coding, simplifying medication algorithms, and making data reporting easier? How can the team effectively and efficiently ensure patients submit proper number of blood pressure readings? How can they be seeing that data in a way that really makes it efficient and effective for them to be communicating with patients and with other members of the team? And then how can you be using some of the pre-visit planning tools like chart prep, or if you've got a population health management system, most of them have a pre-visit planning or huddle tool that you can be used so that you don't miss opportunities to enroll patients, and you have encourage them to continue to take their blood pressures at home when they do come to the office or when you are having an interaction with them. Next slide. And then identifying those patients that need more attention. There are going to be patients that move through SMBP monitoring and reach their goal blood pressure quicker than others. And sometimes we're spending 80% of our time on 20% of our patients. So thinking about how that group could get moved into a care management, more into chronic condition or care management, and then that's a billable, that's an opportunity for billing. And I'll talk about that a little bit more in revenue. So maximizing your revenue. So the Medicare fee schedule was changed to allow billing for multiple services for a patient in 1 month for FQHCs. So are you taking every opportunity to bill when caring for your Medicare patients? Are clinical pharmacists billable providers in your state? That's changing. So staying on top of that is important, and are you exploring every opportunity to bill for their services? Do you have integrated behavioral health? And are you referring patients for assistance with lifestyle changes? Again, it's possible to bill for more than one service in a month, and even in a day if you're using the right modifiers. Can nurse visits for blood pressure checks be converted to a private provider or pharmacist visit if appropriate? How can you be looking for those opportunities? And then reviewing your insurer contracts for incentive and value-based care opportunities. Many insurers offer incentives for using CPT2 codes, for example, and other things like that that would enhance your revenue. Next slide, please. So in summary, don't hide your lights under a bushel. Market SMBP as a service, setting your practice apart. My hunch is that's not available everywhere in your area, and it's an important thing to highlight. Consider the 3 aspects of SMBP monitoring: the cost, streamlining processes, and the potential revenue streams. Engage the team delivering the service to troubleshoot and problem solve. They often have the answers, and we don't always turn to them. So just because a workflow is established doesn't mean that it's going to continue to work, and may need to be revised over time. And then reach out to your peers, and particularly people in the SMBP forum and at Million Hearts. If it's a struggle for you, others have probably encountered it and maybe even solved it, but 2 heads are better than 1. So thank you for this opportunity, and we look forward to the conversation.
Thank you, Deb. I'm now going to hand it over to Haley to lead us in our open discussion portion of the forum.
Thank you very much, Leanne. Happy to lead today's moderating session. I'm Haley Stolp. I'm a health scientist on the Million Hearts team, and I do see some questions already coming into the chat. The Q&A is open. Feel free to put them in there. We'll be incorporating them into our discussion session this afternoon. We've got about 20 minutes, so there will be a deep dive into the topic of efficiency and reimbursement and sustainability, rather, of SMBP. First question for the group, and this is for the panelists, but also, again, please encourage you to raise your hand to join the conversation and or engage through the chat. We'll have an open discussion on these topics. Let's explore the methods to streamline the processes. So if you have coverage, we heard from Deb some of the topics related to this. If there's any best practices you have and methods or strategies, again, to streamline the SMBP processes in your practice to deliver SMBP. And we'll check. I don't see any hands raised. Any comments on methods that have been adopted? If not, we can move on. We have questions regarding access with payers and engagement with payers. And this can really get deep. We've got payment for devices. We've got payment for services. I saw a question in the chat on devices and how to ensure the devices that are used are validated, are the correct size, are perhaps calibrated for pregnancy populations. Have partners on the call today engaged with payers to ensure some of these devices, or had discussions perhaps with payers to ensure the devices used and covered are in fact meeting the needs of those patients? Again, feel free to raise your hand and or participate in the chat. Not seeing hands raised.
Would you like
Go
me
ahead,
to
Deb.
weigh in on
Please.
validated devices? So there are a number of places where you can find, you can go to the validatebp.org to find those validated devices. I think that where we have seen success is where we're using 1 or 2 validated devices for enrollment so that we know how to get things set up, and using a single sort of third-party app so that it's a very standardized process. Recently, we've opened conversations with the payer to see if we can have the devices on site that we want to be using, and then bill for that device either through a DME benefit or through a pharmacy benefit. And we're not quite there yet, but I will tell you that they have been very open to the conversation. It's a logistical issue, but what I'm encouraging you to do is to have those conversations with the payers, because many times they offer a benefit, but that benefit is sort of hit or miss used because it's up to the patient to obtain the device, bring it back, and deal with all of those kind of logistics of it. I hope that's helpful.
Thank you, Deb. Yes. And there's 2 links in the chat highlighting the Validate BP and also the Stride BP as resources to find those validated devices. I also appreciate the comment, using a digital platform connected to our SMBP devices has helped streamline our processes.
Haley, I believe Janine has her hand raised.
Yeah, go ahead, Janine.
I'm going to unmute you, Janine. There you go. Okay, you should be able to participate.
Are you there, Janine?
We can't hear you. Let me
Maybe check your mute. One more time, Janine. Can you?
She's
Okay,
adding to the chat.
Just want to comment about the question of, I'm curious if there's future routes for reimbursement of SBP delivered in community settings with clinical support. Example of the YMCA model. Interesting comment. I am excited to see some new reimbursement opportunities for community health workers. So that might be coming down the path, but appreciate that comment.
And Haley, let me chime in a teeny bit on that question also, of just the need while we're promoting SMBP. SMBP for as part of lifestyle, and that sort of not just out of office, but not connected to clinical, is not where any of the reimbursement has been going, or to my knowledge, will be going. Again, most of the data that we talked about at the very beginning of this, as far as the AHRQ review, was all about with clinical intervention. So it being able to help diagnose, help up titrate, et cetera. Then that's not to dismiss the importance of the lifestyle and the SMBP for just those sort of self-efficacy. But from a reimbursement standpoint, if others are aware, please chime into the chat. But I don't know that that's where any of the pushing is going. So even as Matt was talking about Medicaid coverage, it would be Medicaid coverage for within the clinical situation. So it's a great question. But to my knowledge, I don't know that that's where any of the advocacy is. Thanks.
We'll see if Janine has access to the audio. All right, as we're waiting for Janine to join us, I have seen a couple questions and a comment about billing Medicare for RPM services. I do know we've got a couple coding experts on the call. If anyone has comments to share on, or maybe you can use the React button to indicate if you have successfully billed Medicare for RPM services. Seems to be some questions on how to go about that process. Any comments on billing Medicare for RPM? Again, distinct from SMBP, but a type of RPM is what we consider SMBP. Not seeing any comments or reactions. It appears that there hasn't been much success in billing Medicare for RPM. Deb, if you have a comment on that, or Meg, I don't know if you've heard.
Well, I really would like to hear from Janine, because I know that her group has did initiate billing for SMBP through Medicare. And she's just having some technical challenges to be able to be unmuted and speak to that. One comment about, okay, so Andrew just put in the chat that he's attempted, but so far claims have not successfully come through. Andrew, I don't know, Haley, do you want him to unmute and like add a little color to that?
Yeah, we can do that. If we can unmute Andrew. In the meantime, I see Meg's hand up. Meg, if you've got comments to share.
Yeah, I just wanted to say, you know, I'm the question. So when people put RPM now, I'm like, are they meaning remote physiologic monitoring, or are they meaning SMBP? But assuming that you mean remote physiologic monitoring, you know, I have not done this at the national level, but I can share with the group that in January of 2024, CMS began reimbursing community health centers separately from the Medicare PPS encounter rate for remote physiologic services for their Medicare Part B beneficiaries. So you need to meet the compliance requirements. So remember, that's different than the 12 readings in a month. It's 16 days of blood pressure measurement. So it's a lot more required for that. But I think I would be really curious if people are trying that. I really encourage folks to, because it's an opportunity. As Deb was laying out, you know, we need to kind of grab a hold of all of those opportunities.
Thank you, Meg. I think we have Janine now. Janine, you want to try? Shoot. I think I just saw her on and she escaped off. I see Lee Williams has her hand up. We can unmute Lee. And then we'll go back to you, Janine. Lee, are you with us? Ooh, seem to have some trouble with the audio. No, we can't hear you, Lee. Make sure you're off mute.
Hello, can you hear me now?
Yes, there we go. Hi, Lee. Welcome.
Awesome. I'm sorry, I was trying to speak and it wasn't working. Thanks for
No
having me.
problem. Please
Um,
introduce yourself.
Sure, my name is Lee Williams and I am with AAPC. AAPC is a professional organization that credentials medical billers, coders, practice managers. So basically the revenue cycle side of the clinic or facility. And I am the on the training and education team at AAPC. Thanks for having me. I did want to chime in on the Medicare question. We're an organization, like I said, that trains individuals. So we're not a clinic. We don't see patients, but we do help our partner provider groups and facilities around billing and documentation requirements. And we have had some facilities or organizations, I would say, who has had success around RPM. Especially as Medicare opened up telehealth services as a result of the pandemic. What we often see in review of medical records is that the criteria just hasn't been met. I think a couple people already alluded to the number of days that's required. So for providers looking to build a service, they just have to understand that there is established criteria and the documentation has to support the dates of service, the diagnoses. They are going to really scrutinize these types of services. So we just want to make sure that you are capturing the documentation and that you're meeting the requirements when it comes to the dates of services required. Keep in mind also, sometimes there are multiple providers or organizations, unfortunately, are doing the same service. And sometimes it's whoever submits that claim first gets paid, unfortunately. So that's something to also be aware of, just having those conversations with the patients, properly identifying what other services they're receiving elsewhere to ensure there isn't double billing. But I just wanted to say that we have seen some success. Unfortunately, we've seen denials as well, but it's not a situation where no one is getting paid. I'll say that.
Thank you for those comments, Lee. Appreciate that.
Sure.
Janine Gibbons, are you with us?
Can you hear me now?
Yes, we can. Go ahead.
Okay, well, I won't ever try Microsoft Edge again to join a meeting. That was my difference. Yeah, it changed today. I'm not sure what happened. Yeah, I apologize for that. Yeah, as Deb was mentioning, we've been trying a few different things. As Deb did mention, we have been fairly successful in amending some of our contractual language with one of our MCOs to allow for SMBP billing. So this is a Medicaid provider. They have agreed to pay us for essentially two separate services, one being kind of enrollment, and the fee that they've agreed to does cover the cost of the cuff we use internally and give to the patients. So the patients are essentially using a cuff that we purchase and provide to them, not the cuff that may be provided by the DME company utilized by the MCO. And they're also reimbursing for, again, a certain level of monitoring. They are using the Medicare standard for that, so 16 days. But we are able to submit for those two services. And we worked with Deb. Going back to the streamlining question, we did work very closely with Deb to design a template for our EHR that would allow for automated billing. When we first did the pilot with the MCO, that was probably in 2023. We piloted with the CMO a small number of patients, and we were submitting everything to them manually. But we have since been successful at incorporating the billing into a template within our EHR and automating that process. And it is working, and we've been able to expand it across our sites. To the Medicare question, I'll be very curious to see if we get paid. We have done on a very small scale. I guess we have maybe 80 right now, 80 to 100 patients enrolled in our chronic care management program. And we do get paid for that. That has been successful over the past year. So what we've been doing the last 2 months, now that we have this template up and working, is trying to enroll those eligible chronic care management patients to the SMBP program if they have not previously been enrolled, and then billing for both services. So we just changed some of the back end billing systems internally. I don't know exactly what we do because that's not my area of expertise, but I know that that they did that. And then we will be meeting with our billing department at the end of the month to see, if we have been paid for those claims. So we use NextGen.
Thank you for this comment, Shane.
Yeah. So,
Yeah.
but yeah, much of it thanks to Deb and her leadership.
Lots of navigation, but glad to hear the ongoing communication with MCO and having that
Yeah.
process.
Yeah. And I think, I think if we had, it's funny, like someone mentioned, Lee, about the chronic care and the RMP. We had started with the chronic care before, we were able to bill for both services. So it is interesting because it kind of feels like we're going backwards because we've never kind of considered those. I like what Deb was saying, like perhaps the 20% more difficult patients we could have managed more by chronic care, but we were kind of doing them separately just because of staffing. And we're seeing now it makes a lot more sense for those patients that are both chronic care and hypertensive and difficult to manage, that we have just the one nurse overseeing them. I mean, the results have been better, the patient experience is better, so has the retention, because like getting those 16 measurements can be difficult. So having that much closer relationship with the chronic care nurse has also helped with that.
Excellent. Thank you for those insights. I want to move back to the device coverage. I see a question about, has anyone successfully billed through a DME, so the durable medical equipment, to get reimbursement and a device from Medicaid? I've heard that's that can be a barrier with some of the Medicaid policies, that you have to go to a certain DME supplier to find out which DME supplier, to travel to the DME supplier to get the cuffs. That can be an issue. Any comments or workarounds perhaps, or solutions to address that barrier from the group? See if you see any hands or comments in the chat. You recently heard this is a prominent barrier in Alaska that has a very high reimbursement rate. And actually, the other question is just the Medicaid coverage as a whole. So if we could put the link to the Medicaid document again, you can see the reimbursement amount. So you'll see some devices that may not have sufficient coverage. I think it's Arkansas, the $8 device. That might even be a manual device, although it's coded as automatic. I don't know what kind of device would be available for $8, but for Alaska, I believe it's $100 or more. But again, going through the DME suppliers, the barrier there. Yeah, Deb, go ahead.
So what we're working on right now is having actually a cabinet that would contain the blood pressure devices that would be at the site, that once it was being issued to a patient, that will create a billing situation. The particular company that's used is called Stellar RX with our MCOs that we're working with here in Pennsylvania. I don't know if they're national or not, but there is some precedent around having that kind of a scenario where they're actually on site, but they're in a sort of locked cabinet that then once you are initiating the order for DME with that patient, it's unlocked, it's delivered to the patient, and that creates the billing. So I just would encourage folks to ask the question of the insurers that you work with.
Thank you for that, Deb. I know that was a best practice also of Joe Humphrey in Hawaii, having a supply of devices. Any other comments or questions on working through a DME supplier? Mhm. Excellent. How about the third question on the screen? Have you explored other potential revenue streams to sustain SMBP delivery? Again, the issue that Medicare does not yet cover a device for people with hypertension. Only end-stage renal disease patients is where Medicare coverage currently lies. But other successes in finding devices from other sources, perhaps local grants. Has anyone had success exploring other revenue streams beyond the traditional reimbursement through coverage? Janine, go ahead.
No, we have utilized other sources. Initially, we had a HRSA grant to kind of jumpstart the project, and that allowed us to buy a number of cuffs. We thought that we may do a lender program at that time, but quickly kind of dismissed that idea when we saw how much the patients appreciated having the cuffs even after they graduated from the program. And then also a number of the patients do come back into the program. And we have applied for some other grants and have earmarked some of that money to buy cuffs, especially when we were winding down our HRSA grant. So sustainability over the long term, we're really, counting on the payers, but in those sort of years in between where we are now, we've utilized other grants.
Thank you for those comments. We've also seen a lot of success with loaner programs, so perhaps not giving out the device, and there's a number of resources available through Target BP on how to set up a loaner program if that's of interest. And then we've also heard from health centers bulk payments of devices to one location can help reduce some of the costs as well to maximize those dollars available for purchasing devices. I do see a question. Does Medicare Part B cover the DME for device cuff? I think we addressed that, that no, currently Medicare does not cover the device cuff unless you have a patient with Medicare beneficiary with end-stage renal disease, and that's part of the end-stage renal disease services. But currently Medicare does not cover a device for the purpose of SMBP. A lot of Medicare Advantage plans have a credit benefit that can be used for over-the-counter items and can be used on blood pressure monitors. If patients buy a validated device, can there be a workflow for that type of arrangement? I want to refer you, Patricia, yes, I think there are some over-the-counter benefits. There's also catalog options for some Medicare Advantage. There's some of the funding that's available through Medicare Advantage plans can be used. Some of those benefits can be used to purchase a device through those catalogs. We did a coverage analysis in 2020 in collaboration with our National Association of Chronic Disease Directors colleagues. And I do see Susan Spencer's on the call. Susan, if you want to put a link to that coverage analysis, we point to some of those Medicare Advantage coverage options and how that was addressed by some of the Medicare Advantage beneficiaries. I hope I answered your question, Patricia, but I think the question remains, though, if those devices are validated, if they see those same devices on the BDL. But there are options to use Medicare Advantage benefits to purchase those devices over the counter. Thank you so much. Really appreciate the ongoing collaboration. I might just pause and see if there's other questions. I see Allison Smith from Target BP put the loaner program resources. Thank you so much. Anyone else has had success finding other potential revenue streams in the practice? I appreciate the comment of Medicare Advantage providers. The question that keeps remaining on the screen, though, is selected validated devices that be integrated into your existing EHR with the least cost complexity, like integration engines. I think that is the vision, Allison. Really appreciate that question, is that they will be seamless. And we know that the electronic health records, Meg, actually, I might see if you would be available to speak to the USDVI and when those average blood pressure might be part of the EHR as a structured data field.
Yeah, I think Deb knows as much about this as I do, but the U.S. core data and information set, one of the things that was successful was our advocacy for average blood pressure to be included as part of that, which means that in the future EHRs, if they want to be validated EHRs, have to include that as a structured data element. I think the challenge is that it's, that's some years down the road. I'm guessing maybe at the earliest 2025, and then there's of course, the enforcement of it. So it's certainly a positive step in the right direction. I think the other piece to it is there are other elements that we need alongside of average blood pressure to really have sort of a robust data section for SMBP. Do you want to say a word or two more about that, Deb?
Yeah, thank you for the question and the opportunity to respond to it. I earlier today, I was on a call with our HL7 accelerator partner by the name of Cardex. We're in the process of working on an integration guide for exactly that, to get SMPP values directly into the chart. The hope is that providing some integration guidance that's a little more standardized, it will accelerate this process through the EHRs. There are two main issues. One is that typically there is no average blood pressure reading data point in the EHRs in their current databases. And secondly, blood pressure values are typically collected within an encounter, which is very different from the way that we do SMBP. So these are things that we're trying to address in the integration guide. It's going into testing this fall, and we hope that it'll get passed through the HL7 processes and be available so that more EHRs will do that integration, coupled with what Meg was just talking about with the US CDI. Now that average blood pressure is a requirement, is a sharing requirement. So.
Thank you, Deb. I think we are at time for our discussion panel. We'll continue to answer some questions in the chat. I've got a couple drafted, so we'll continue to move on, but I'll pass back to Leanne to talk about some next steps and the survey that we want to make sure we've got plenty of time for you all to complete. Thank you so much for your discussion.
Thank you, Haley, and thank you to all of our panelists and engagers in the audience. So glad that you could join us and really engage on this topic. So I'll just kind of plug in. We have an upcoming event that we hope you can all join us at. It's our Million Hearts Learning Lab. It's Hypertension in Pregnancy, Impactful Strategies and Tools on July 11th from 1 to 1:45 p.m. Eastern Time. We'll also go ahead and drop the registration link in the chat. So please feel free to join us. We'd love to have you. And then here is some of the resources that we covered today. Many of these were added in the chat throughout our forum today. And we will also make sure to put these on our Confluence page. We will also drop the Confluence link into our chat as well. Come take a look at the slide deck, the recording, the resources, and then we'll also, you can also find previous recordings, resources, and slides as well from our previous forum. So please come take a look. I'm happy to have you. And then the survey Haley mentioned just recently, if this is your first forum or you've been coming to many of our forums, we would love to connect with you, and I would love to hear your insights. We want to continue engagement and keep this conversation going. And so please scan the QR code, or we'll also drop the survey link in the chat, but we'd just love to get your feedback on your experience with SMBP forums. I'm going to pause just for a brief second to see if anyone has any questions. I am sharing screen, so I'm going to rely on my teammates to also take a look at the Q&A in the chat before we move on. Just pause for a second. Okay, I think I see a hand raised, so Janine Gibson. Yes.
Sorry, I was just going to say, I was trying to click on the link for the hypertension and pregnancy change package, but it keeps saying it's not found. I'm not sure if.
Okay, perfect. Thanks for letting us know. Yeah, if a member of the team can go ahead and drop the link to the hypertension and pregnancy change, which is a new resource. We're really excited about it. Yes, please come take a look at that. Great resources, great strategies. Definitely take a look at that. We'll make sure you get that link in the chat.
Okay, thank you.
Okay, thanks so much for letting us know. Appreciate that. Okay, well, I'm going to hand it over to Judy for closing comments and thoughts.
Thank you, Leanne, and thank you everyone for your patience with the, I guess people can't speak, and Q&A isn't working, but we got many comments and conversations going, so really appreciate that. So as you've heard, we're a little bit at a crossroads, and we definitely need your input to help us decide our next steps. So I really hope you take some time to do the survey. Today's forum is the last of this year as we close out our cooperative agreement with NAC at the end of July. And the survey will help us figure out where we might want to take the SMBP forum next year. You know, the fact that we continue to get over 100 folks at these forums, there's a part of us that says, I think they're still needed, but we really would like to hear from you to make sure that it's the best use of your time also. Besides the survey, we will also welcome your input at our email address, millionhearts@NACHC.org. And while I have a few moments, I think I'd be remiss if I didn't thank AMA for all their support, guidance, leadership along the way. Allison Smith from Target BP for the generous sharing of resources, advice, and participation. Our numerous other partners for always sharing info about the forum to others. And of course, NAC and the Million Hearts team for years of putting these together. A special shout out to Hillary Wall, who challenged me and the entire Million Hearts Initiative a number of years ago to focus on SMBP more. And Haley Stolp, who has been our behind the scenes hero, regardless of who was in charge to do what. Haley helped make sure it got done. And then, of course, thank you again for your continued engagement and commitment to advancing this evidence-based strategy. Your participation over the years is what made the forum the forum. We have tried to keep true to the let's ask a question, let's hear answers from you all. So a huge heartfelt thanks to your participation over the years. And I think with that, Leanne, I'm able to tell everyone thank you, and we look forward to hearing your feedback in the survey.
Wonderful. Thank you, Judy. Thank you, everyone, for joining. We look forward to hearing your thoughts, and we appreciate your time today. I hope you have a very safe and healthy summer, and thank you so much for joining. Have a good afternoon, everyone. Thank you.